Imagine a baby just stuck mid-delivery. It is this absolute heart-pounding life or death emergency where doctors have, like, mere seconds to act.
Right. It's absolute chaos.
Exactly. Now, imagine asking that same mother months later how she feels and discovering that the immense visceral trauma of that day in the delivery room isn't actually what's causing her the most discomfort.
Yeah, which is wild to think about.
It really is. Instead, it's a quiet, invisible chemical dropping in her bloodstream. So today, we are mapping a very specific journey for Elle. We are connecting the adrenaline-filled reality of a major obstetric emergency to the long-term, often unspoken changes that happen in a woman's body.
And we're doing it to answer a highly specific question.
Right.
Does shoulder dystocia increase the risk of vaginal laxity?
Which is a question that forces us to look at the human body across, several different disciplines: biomechanics, endocrinology, pelvic floor physiotherapy.
Yeah, and to actually get to the bottom of this, we're pulling from a really robust stack of sources. We've got the British Menopause Society's consensus statements, comprehensive reports from Birth Trauma Australia, and some incredibly specific clinical data.
I like that recent PMC paper, right?
Exactly.
Yeah.
The PMC paper focusing on postpartum primiparous women, so first-time mothers. We are looking at exactly what happens to the tissues, the muscles, and the hormones, and trying to separate the structural damage from the subjective feeling of the body changing.
And for you listening, whether you are preparing for childbirth, maybe you're recovering from it, or you're just fiercely curious about how the human body heals from extreme trauma, understanding the difference between a physical injury and a chemical shift is incredibly empowering.
It really is. It completely reframes how you view recovery.
But I mean, to understand the aftermath, we first have to understand the event itself. So when we say shoulder dystocia, what exactly is getting stuck and why?
Well, in a standard, uncomplicated vaginal delivery, once the baby's head emerges, the rest of the body usually follows relatively smoothly, like the shoulders just slide through.
Right.
But shoulder dystocia happens when the baby's anterior shoulders, that's the shoulder facing the mother's front, becomes phytically impacted. It gets wedged incredibly tightly behind the mother's pubic symphysis, which is the joint at the front of the pelvis.
Oh, wow.
Yeah. And less commonly, the posterior shoulder gets stuck on the sacral promontory at the back. But the end result is the same. The baby's head is out, but the body is trapped in the birth canal.
Reading through the clinical sources, there is a very specific and honestly terrifying visual cue for this that doctors look for. They call it the turtleneck sign.
Yes, that's exactly what it looks like.
The baby's head actually emerges, but because the shoulder is pinned against the mother's bone, the head retracts tightly back against the perineum. It looks literally like a turtle pulling its head back into its shell.
And that retraction is the undeniable signal that the medical team has a severe emergency on their hands. This happens in roughly 0.6% to 3% of vaginal births.
Which doesn't sound like a lot, but when it happens, the stakes are sky high.
Absolutely. And the reason it is so critical is the umbilical cord. When the baby's body is compressed in the birth canal like that, the cord is often pinched off. It severely restricts or completely cuts off the baby's oxygen supply.
So the head-to-body delivery time just becomes a ticking clock.
Exactly. The attending medical team can't just wait. They have to perform immediate interventions to physically free that trapped shoulder.
And these are not gentle adjustments from what the sources say.
Not at all. The first line of defense is usually the McRoberts maneuver. The team will take the mother's legs and hyperflex them tightly back against her own abdomen.
Just to change the angle of the pelvis.
Right. The goal is to literally flatten the pelvis and rotate the angle of the pubic symphysis to hopefully let that shoulder slip past. If that failed, they might perform an episiotomy.
Which is a surgical cut to the perineum to widen the vaginal opening.
Correct. But crucially, the episiotomy doesn't free the trapped bone. It just makes enough physical room for the doctor to get their hands inside the birth canal to attempt internal rotational maneuvers. They're trying to manually corkscrew the baby out.
And if those maneuvers fail, I mean, the protocols get extreme. The sources detail procedures like deliberately fracturing the baby's clavicle.
Yes, snapping the collarbone.
Just to collapse the width of the shoulders so the baby can fit. Or the Zavanelli maneuver, where the doctor actually pushes the baby's head back into the birth canal so they can rush the mother into an emergency C-section.
It's intense. It's a true medical crisis.
Okay, let's unpack this.
Right.
If we know a baby is macrosomic, meaning, they are weighing in at over 8 pounds, 13 ounces, or if the mother has gestational diabetes, which we know reliably causes larger babies, why is this still considered an unpredictable emergency?
You'd think we'd see it coming.
Right. If the stakes are this high, can't we just measure the baby beforehand and schedule a C-section to avoid the whole thing?
It seems like such an obvious solution, but the clinical reality is vastly more complicated. The Royal College of Obstetricians and Gynecologists, the RCOG, publishes the Green Top guidelines on this,
Yeah.
and they explicitly state that you simply cannot reliably predict shoulder dystocia.
Really? Not even with modern imaging.
Not reliably, no. For one thing, measuring a baby in utero during the third trimester is notoriously difficult. You are trying to estimate the weight of a scrunched-up infant through layers of amniotic fluid and tissue using ultrasound, which has at least a 10% margin of error.
Wow.
Yeah, that's a massive window when you're talking about clearing a pelvic bone by millimeters.
So the ultrasound might say the baby is 8 pounds, but they're actually pushing 9 or 9.5?
Exactly. But here is the truly staggering statistic from the RCOG guidelines. 48% of all shoulder dystocia cases happen in babies weighing under 4 kilograms. That is roughly 8.8 pounds.
Wait, so nearly half of these terrifying emergencies happen with babies that are essentially average weight?
Yes, because the mechanics of how a baby navigates the unique architecture of a woman's pelvis are so complex, and they rely on so many minute shifts in position, that the vast majority of these cases occur in women with absolutely no clinical risk factors.
That's wild.
You can have a perfectly average-sized baby get stuck and a massive baby slide right through.
That feels entirely counterintuitive, but it really underscores why the delivery room can go from completely calm to a crisis in like a matter of seconds.
Wow.
So they managed to get the baby out safely. The emergency's over for the infant.
Right.
But looking at the extreme forces you just described, the trapping, the stretching, the aggressive internal maneuvers, what does that actually do to the mother's pelvis?
The physical toll is immense. To understand it, you have to picture the pelvic floor. It is essentially a muscular hammock made up of connective tissue, ligaments, and importantly, the levator muscles.
Which hold everything up, right?
Exactly. This hammock holds up the bladder, the uterus, and the bowel. During a normal, uncomplicated vaginal birth, those levator muscles have to stretch to an almost unbelievable degree to let the baby pass through. We are talking about muscle fibers stretching 1.5 to over 3 times their normal resting length.
Think about that. I mean, imagine a thick, heavy-duty rubber band stretched 3 times its normal size. It's taut. It's at its absolute physical limit.
Right.
Now imagine a 9-pound weight getting abruptly stuck right in the middle of it while it's fully stretched out. The rubber band isn't just stretching anymore. It's bearing a static, crushing load. That is shoulder dystocia.
And that is exactly why Birth Trauma Australia explicitly flags shoulder dystocia as a major red flag for severe pelvic floor muscle trauma. The specific trauma they were looking for is called a levator avulsion.
And an avulsion is different from a normal tear, right?
Very different. An avulsion isn't just the tissue overstretching or sustaining a minor micro tear. An avulsion is when the pelvic floor muscle is literally sheared or torn entirely off its attachment point on the pubic bone.
Oh my God, off the bone.
Yeah. And the clinical data on this is sobering. When a levator muscle avulses, it permanently weakens that muscle group by roughly 1/3. It makes the remaining muscle 25% stretchier because it's lost its anchor.
Right.
And because that hammock is now structurally compromised on one side, it more than doubles the woman's risk of developing pelvic organ prolapse later in life.
But wait, if a muscle is physically tearing off the pelvic bone, you would think that would be the most excruciating pain imaginable. Does the mother feel that happen in the moment?
What's fascinating here is that overwhelmingly, the mother rarely feels the avulsion happen.
How is that possible?
You have to put yourself in the environment of that delivery room.
Right.
There's the sheer chaos and panic of a life-threatening emergency. The mother's brain is flooding her system with massive, unprecedented amounts of adrenaline just to cope.
Okay, that makes sense.
And on top of that, in a huge percentage of cases, there is regional anesthesia, like an epidural, actively numbing the pelvic region. All of those factors combine to completely mask the injury.
It's a completely hidden trauma. The doctor is focused on saving the baby. The mother is numb and running on pure adrenaline. So a major muscle tears off the bone in silence.
Precisely. It is very frequently overlooked in the delivery suite. Even if the doctor is stitching up a visible surface tear on the perineum, they might not realize the deep muscle beneath it has detached from the bone.
Wow.
Proper diagnosis of an avulsion usually happens much, much later. It's often confirmed by a specialized pelvic ultrasound months down the line when the functional symptoms finally start to manifest.
And what do those symptoms actually feel like?
They usually present as a heavy dragging sensation in the pelvis,
Yeah.
or a woman might actually feel a visible bulge protruding into the vagina. Those are the classic signs of a cystocele, which is a bladder prolapse, or a rectocele, where the rectum is bulging forward into the vaginal wall because the muscle that used to hold it back is gone.
Okay, so the mechanical reality is clear. Shoulder dystocia causes immense physical structural damage. But our core mission for this deep dive is to figure out if it causes vaginal laxity. And this is where we have to be incredibly precise with our definitions, because looking at the sources, prolapse and laxity are two very different things, even though they get lumped together all the time.
They are entirely different clinical entities. Up to 58% of new mothers experience vaginal laxity, making it incredibly common. Prolapse, as we just established, is an anatomical, structural dropping of the pelvic organs.
Right, it's a physical failure.
Exactly. It is objective.
Yeah.
It is measurable by a doctor using standardized physical grading systems like the POPQ. Vaginal laxity, on the other hand, is defined clinically as a subjective sensation. It is the patient's own internal perception of looseness.
The sources describe the symptoms of laxity as a loose feeling, literally trapping air inside the vagina during movement, a significant decrease in physical sensation during intimacy, and a loss of sexual pleasure.
Which is incredibly distressing for the patient.
Absolutely. So to use an analogy to keep them straight, a prolapse is like the actual ceiling of your house physically caving in and dropping into the living room.
I like that.
Laxity is feeling like the room has just gotten drafty and far too spacious, even if the ceiling is technically intact.
That is an excellent way to conceptualize it. And while laxity can certainly be related to the mechanical stretching of childbirth, that global stretch of the tissue, there is a massive, often completely overlooked driver behind that drafty feeling. Hormones.
Yeah.
Specifically, the sudden dramatic drop in estrogen.
And this is where the British Menopause Society data comes into play, which feels strange at first, right?
Yeah.
We are talking about postpartum women in their 20s or 30s, not menopause.
It does seem counterintuitive until you look at the endocrine system. Immediately after birth, a woman's hormone profile completely flips. Especially if a mother is breastfeeding, her body produces massive amounts of a hormone called prolactin, which drives breast milk production.
Right.
But prolactin has a secondary job. It aggressively suppresses estrogen.
And just to clarify the biological logic here, nature designed it that way to essentially act as natural birth control, right? Suppressing estrogen stops ovulation, which spaces out pregnancies, so a mother isn't trying to nurse an infant and grow a new baby at the same time.
Exactly. It's an evolutionary mechanism to protect the mother's resources. But the side effect is that her pelvic tissues are suddenly starved of estrogen. This creates a recognized clinical condition known as the genitourinary syndrome of lactation.
And that's similar to what happens in menopause.
Functionally and microscopically, it is nearly identical to the genitourinary syndrome of menopause, or GSM.
So laxity isn't just about the muscle getting stretched out by a baby, it's a chemical withdrawal.
It is a deep interplay of both, but the chemical side dictates the health of the tissue itself. Let's look at the histology, what's actually happening at a microscopic level. The vaginal wall has multiple layers. The very top layer, the mucosa, relies completely on a steady supply of estrogen to stay thick and healthy. In an estrogen-rich environment, the cells on the surface shed regularly, releasing a sugar called glycogen.
Like food for the bacteria.
Yes. That glycogen feeds healthy bacteria lactobacilli, which keep the whole ecosystem acidic, lubricated, and healthy.
But when prolactin spikes and estrogen drops, that whole ecosystem just crashes.
It crashes hard. The mucosa stops shedding glycogen, the healthy bacteria die off, and the tissue thins out significantly. But it goes deeper than that. Beneath the mucosa is a layer called the lamina propria.
The scaffolding.
Think of it exactly as the scaffolding of the tissue. It's full of cells called fibroblasts that produce collagen, giving the tissue its bounce and stretch. Without estrogen, those fibroblasts basically go to sleep. They become dormant.
And what happens to the collagen that's already there?
The clinical term is that it hyalinizes. To put it simply, without the hydration and chemical signaling from estrogen, those collagen fibers dry out. They fuse together. They lose all their bounce and elasticity.
Oh, wow.
The tissue literally changes its fabric. It becomes thin, dry, and rigid. So yes, the mechanical stretching of birth widens the physical space, but the hormone deprivation changes the very texture of the walls, making the whole area feel thin, dry, and internally loose.
Which brings us to the core question, the verdict. Does the extreme violent mechanical trauma of shoulder dystocia cause this sensation of vaginal laxity?
And to answer this, we have that highly specific cross-sectional observational study from our PMC source.
Right. They looked at primiparous women, first-time mothers, and evaluated them 6 months postpartum.
And focusing on first-time mothers is a brilliant study design because it isolates the variables. You don't have to wonder if their symptoms are from a previous birth. It's a clean slate.
Makes sense.
The researchers evaluated these women at the 6-month mark for a whole host of pelvic floor issues: urinary incontinence, bowel issues, pain, and their subjective feelings of vaginal laxity.
And the findings are a bit mind-bending. The study confirmed what we talked about earlier. Shoulder dystocia was absolutely a predictive factor for severe structural damage.
Yes.
Specifically what they call OASI, or obstetric anal sphincter injuries, severe measurable tearing. But when they looked at the data for vaginal laxity, well, they found absolutely zero direct association between having a shoulder dystocia emergency and complaining of vaginal laxity at 6 months.
None at all.
Here's where it gets really interesting, because mechanically, how does it make sense? If a 9-pound baby gets stuck, the levator muscle is stretched past its breaking point. It shears off the bone. The muscle becomes 25% stretchier permanently. How does that massive structural failure not equal the sensation of vaginal laxity?
If we connect this to the bigger picture, it all comes back to that crucial distinction between an objective structural failure and a subjective sensation. Think about what shoulder dystocia actually does.
It tears things.
It causes acute, severe focal damage. It causes 3rd or 4th degree perineal tears, severed nerves, and those levator avulsions. Those are localized, catastrophic structural injuries, and they result in very objective problems: hemorrhage, severe pain, anal incontinence, or a measurable pelvic organ prolapse.
That's the ceiling caving in. The structure broke in a very specific place.
Right, the structure broke. Vaginal laxity, however, is a widespread global sensation. Yeah. It is driven by the general, all-over stretching of the vaginal walls, and most critically, that chemical shift, the estrogen deprivation drying out the collagen.
Ah, I see.
Now, here's the key. That global stretch and that massive estrogen drop happen in normal, uncomplicated vaginal deliveries, too. The extreme, acute trauma of a stuck shoulder leads to localized structural injuries, but it does not necessarily increase the global subjective feeling of looseness compared to a standard, non-emergency vaginal birth.
That is fascinating. The most dramatic physical trauma doesn't trigger the sensation of looseness. The quiet, invisible drop in hormones does.
Exactly.
So for the listener who is navigating this, whether they are dealing with the structural fallout of a difficult birth or just the frustrating laxity of postpartum hormone shifts, what is the path forward? What does the clinical evidence actually support for healing this tissue?
The sources across the board are unanimous in advocating for conservative, evidence-based care as the very first line of defense. If you are dealing with pelvic floor trauma, weakness, or laxity, the gold standard is pelvic floor muscle training, or PFMT.
And just to be clear, this isn't just doing Kegels in the car.
Oh, absolutely not. This is not just doing a few haphazard Kegels while you're waiting at a stoplight. It requires working with a specialist pelvic floor physiotherapist on a targeted rehabilitation program.
What do they actually do?
They use biofeedback to ensure you're actually recruiting the right muscles, rebuilding muscle volume, and addressing any nerve damage. It is physical therapy, and it typically takes 6 to 16 weeks of consistent guided work to see significant clinical results.
And what about the chemical side of the equation? If the tissue is essentially starving for estrogen, how do we fix the ecosystem?
This is where localized hormonal support is incredibly effective, and the British Menopause Society consensus statement strongly supports it. We aren't talking about systemic hormone pills that affect your whole body.
Right.
This is local vaginal estrogen, usually applied as a cream or a tiny dissolvable tablet right into the tissue.
So it goes straight to the source without disrupting breastfeeding or anything else.
Exactly. There's also a treatment using DHEA, clinically known as progesterone, which is fascinating because the vaginal tissues actually convert it locally into both estrogen and testosterone as needed.
Oh, wow.
Yeah, there's even a newer oral medication called ospemifene, which acts specifically on the vaginal tissues to mimic the effects of estrogen. What all these treatments do is wake up those dormant fibroblasts.
They turn the factory back on.
They do. They restore collagen production, bring the glycogen back to feed the healthy bacteria, and bring hydration and plumpness back to the tissue. It treats the chemical withdrawal at the root.
But I have to ask about this because, you can't scroll through social media without seeing ads for it. What about these vaginal rejuvenation lasers?
Ah, yes.
The marketing promises to fix laxity and restore tightness in like a 20-minute session using lasers or thermal energy. Why would a new mother commit to 16 weeks of intense physical therapy and daily hormone creams when they could just go to a med spa and get a laser treatment?
This raises an important question, and it is an area where the medical guidelines issue very stark, very serious warnings. Energy-based devices, these use CO2 lasers or radio frequency, to intentionally create microthermal injuries in the tissue, with the idea that the burn will trigger collagen rebuilding, are highly controversial.
Because you're essentially burning an already thin, dry, compromised tissue.
Precisely.
Yeah.
And the major regulatory bodies are pushing back hard. The UK's NICE guidelines restrict the use of these lasers for urogenital issues to research settings only.
That's a massive red flag.
They explicitly say they are not approved for routine clinical use because the long-term data just isn't there.
If NICE says it's research only, it's essentially experimental.
It gets even stronger globally. The US FDA has issued strict public safety warnings regarding these specific devices, noting that they have seen reports of severe burns, scarring, and chronic long-term pain from women trying to treat laxity.
That's horrifying.
And taking it even further, just recently, in 2025, the medical regulator in Australia reviewed all the clinical evidence and entirely canceled all approvals for vaginal rejuvenation devices.
Banned them completely.
Yes, they cited a total lack of proven efficacy and severe safety concerns. The message from the clinical community is incredibly clear.
Well,
Avoid heavily marketed, expensive, quick fixes.
right.
Trust conservative, proven care. Work with a physiotherapist, address the hormones, and give your body the time and the correct environment to heal itself.
So what does this all mean? We started this deep dive looking at one of the most frightening adrenaline-fueled emergencies in obstetrics shoulder dystocia, a moment of intense, unpredictable physical force.
Oh, you did.
And we set out to map whether that acute mechanical trauma was the culprit behind the lingering, frustrating sensation of vaginal laxity.
And what we found is a profound separation of pathways. Severe birth trauma, the stuck shoulder, the emergency maneuvers, the avulsed muscles carrying off the bone creates visible focal structural damage. It causes tears, it causes weakness, it causes prolapse. But the sensation of laxity, that global feeling of looseness and a loss of internal connection, operates on a totally different pathway.
Which is wild to think about.
It is a complex symptom driven by the global stretching of the tissue and the quiet, invisible withdrawal of hormones like estrogen. Understanding your body and knowing how to heal it means learning to separate the visible structural damage from those invisible chemical shifts.
It really reframes everything. It's not just about a surgeon stitching up a structural tear. It's about restoring an entire microscopic ecosystem that got starved of its primary fuel.
Exactly.
Which leaves me with a final thought for you to mull over today.
Mm.
We tend to trust what we can feel. But if our perception of our own physical tightness, our own bodily boundaries, or our sense of internal looseness is dictated more by an invisible chemical like estrogen dropping quietly in the background than by the incredibly violent physical event of a 9-pound baby getting completely stuck, how much of our physical reality is actually just a chemical illusion?